Hello everyone, myself Somaina Basumatary. Today I'll explain what exactly the tennis elbow is. So let's start. Definition: tennis elbow is also called lateral epicondilitis. This is a condition characterized by pain and tenderness at the lateral epicondyle of the humerus due to non-specific inflammation at the origin of the extensor muscles of the forearm. So here in the picture you can see extensor muscles originates from the lateral epicondyle of the humerus. So inflammation will be at the origin of the extensor muscles of the forearm. Epidemiology: it is more common in men than in women and is believed to be a degenerative disorder. It is sometimes seen in tennis players. Etiology: in tennis players, it may occur due to an awkward stroke, that is, improper backhand stroke, during the game of tennis, also due to overuse of wrist extensors and supinators. Non-tennis players: this group comprised of housewives, carpenters, drill workers, etc. However, it is usually due to an overuse injury in day-to-day activities of pulling, lifting, pushing, etc. Computer-related injuries due to repetitive stress while using laptops, mouse, etc. So here is the picture of proper ergonomics. Our wrist joint should not be extended or flexed position while using laptops, mouse, and also our hand should not be radially deviated or ulnar deviated. Now clinical features: tenderness over the lateral epicondyle of humerus. Pain is aggravated by stretching the extensor muscles. Example: wrist extension against resistance with the forearm pronated. The pain is usually deep and pain can radiate to the wrist or shoulder joint. Any grasping movements are painful and the patient may drop things from the hand. Range of motion of the elbow joint are not affected. Investigations: the anterior-posterior and lateral views of the X-rays are recommended. In 16% of cases, a faint calcification along the lateral epicondyle can be detected, and ultrasonography is also helpful. Diagnosis: special test for epicondilitis. Lateral epicondilitis test, or also called tennis elbow or Cousins test. Purpose: to assess lateral epicondylopathy of the elbow. Patient position: standing or sitting or supine lying with elbow flexion. Examiner position: stands in front of the test elbow. Test procedure: there is two methods, method 1 and method 2. In method 1, one of the examiner's hands supports the patient's elbow. The thumb of this hand rests on the lateral epicondyle. The examiner's other hand grasps the dorsal aspect of the patient's hand. The patient is asked to actively make a fist, pronate the forearm, and radially deviate and extend the wrist while the examiner resists the motion. In method 2, the test may also be done passively by the examiner. While palpating the lateral epicondyle, the examiner pronates the forearm and flexes the wrist fully. Then, while holding these two positions, the examiner extends the elbow. The symptoms would be the same as for the active test. Indications of a positive test: a positive test result is indicated by a sudden severe pain in the area of the lateral epicondyle of the humerus. The epicondyle may be palpated to determine the origin of the pain. Here is the picture of Cousins test. So in method 1, as you can see in the picture, one of the examiner's hand is supporting the patient's elbow and the thumb of this hand rests on the lateral epicondyle. The examiner's other hand grasps the dorsal aspect of the patient's hand. The patient is asked to actively make a fist, pronate the forearm, and radially deviate and extend the wrist while the examiner resists the motion. And in method 2, the examiner's hand placement is same as the method 1. And here the test is done passively by the examiner. While palpating the lateral epicondyle, the examiner pronates the forearm and flexes the wrist fully. Then, while holding these two positions, the examiner extends the elbow. The symptoms would be the same as for the active test. Now coming to management, number 1, conservative treatment. Rest and avoiding movements that causes pain. Non-steroidal anti-inflammatory drugs and tennis elbow splint are used for pain relief, and also injection of local anesthetic, steroid and hydrocortisone acetate reduces pain. In below I have given the picture of tennis elbow splint. Now physiotherapy as part of the conservative management. Cryotherapy, ice pack is given for 30 minutes and ice massage is given for 7 minutes. Next, supportive measures. Rest with a splint holding the wrist in a mild degree of extension and a sling with the elbow in flexion and forearm in supination. Below in the picture, the patient's elbow is in flexed position and forearm in supination or in mid supination and the wrist in a mild degree of extension. Electrical stimulation. In case of tennis elbow, microcurrent stimulation is used, which is a current less than 1 milliampere. Waveform constant or pulsed. Pulsed waveform is used in acute condition and constant waveform is used in chronic condition. Frequency is 0.6 to 680 Hz. Iontophoresis. It is also called ion transfer, where ion is transferred locally. It is a method of treatment which uses direct current to push or drive medically useful ions through the skin into the tissues. Ions such as iodine, chloride, salicylate, zinc, copper, histamine, glycopyrronium are most commonly used. Principle of iontophoresis is based on like charges repel each other. As we all know, same charges repel each other. Ions such as iodine, chloride, salicylate are negative, so this will be placed under the cathode as cathode is negative, and zinc, copper, histamine, glycopyrronium are the positive ions, so this will be placed under the anode as anode is positive. Now dosimetry for cathode 0.5 milliampere per centimeter square and for anode not more than 1 milliampere per centimeter square. Amplitude not more than 40 milliampere per minute. Treatment time. If current intensity is of 2 milliampere, not more than 20 minutes, and if current intensity is of 1 milliampere, not more than 40 minutes. This is the picture of iontophoresis treatment technique. The electrodes under which the ions are placed is called active electrodes. Dipulse ultrasonics, ultrasonography with hydrocortisone cream of 0.05% concentration is used. Dosage parameters, mode, continuous or pulse mode, frequency 1 MHz. In deeper tissue, 1 MHz is used, and in superficial tissue, 3 MHz can be used. Intensity for acute 0.1 to 0.25 watt per centimeter square, for chronic 0.25 to 1 watt per centimeter square. Duration, size of area determines the treatment time. In minimum area 1 to 2 minutes is applied, in average 5 minutes, in maximum 8 minutes. For chronic longer time and for acute lesser time is applied. This is the picture of ultrasound treatment where both the therapist and patient are in comfortable position. Next treatment, gentle effleurage and kneading during the first 2 weeks. In effleurage technique, long stroking movements are performed with flat hand and fingers to increase lymphatic system, and in kneading technique, circular deep pressure is applied. Both the effleurage and kneading massage technique can be applied over the lateral epicondyle. Gentle active movements of the elbow, wrist and hand and isometrics at the end of each range are performed. Mild resistive exercises are also initiated. In picture, the person is performing isometric exercise with the help of TheraBand. In isometric exercise, wrist joint should not be flexed and hyperextended position, because in isometric exercise, the length of the muscle remains same. Operative treatment indications are failure to conservative treatment, marked and localized tenderness over the lateral epicondyle, failure to respond to restricted activity or immobilization for at least 2 weeks, Surgical methods includes percutaneous release of epicondylar muscles, excision of proximal portion of the annular ligament, release of the origin of the extensor muscles, excision of the bursa and excision of synovial fingers. Number 3. Physiotherapy following surgery. Measures to reduce pain and inflammation, limb elevation and sustained active movements to the joints. When mobilization is allowed, slow, relaxed, full passive range of motion to the elbow, forearm, and wrist are performed. Shoulder is mobilized to full range of motion to avoid adhesive capsulitis. Begin with gradual active assisted exercises and progress to self-resisted techniques. Ultrasonics, stents, and dipoles can be used to reduce pain. Functional movements such as repeated supination, wrist extension, strong grip, and eccentric exercises are initiated. Progress gradually to progressive resistance exercises. By 5 to 6 weeks, functionally painless elbow, forearm, and wrist movements should be regained. Tapping and manipulation are also beneficial. Here, in number A, picture of K-tapping or kinesio-tapping is given. Kinesio-tapping prevents overuse of muscle and reduces all the symptoms. In number B, manipulation. In this high velocity, low amplitude thrust is performed at the end of elbow extension while the hand and wrist are flexed. This is also used to reduce pain. Number C is the picture of concentric and eccentric exercise. With the use of dumbbell, when person perform wrist extension, then extensor muscles of the forearm shortens, so it is called concentric exercise. And with the use of dumbbell, when person performs wrist flexion, then extensor muscles lengthens, so it is called eccentric exercise. In concentric contraction, muscle gets shortened, and in eccentric exercise, muscle gets lengthened. Now, preventive management. Activities such as wringing washed clothes, tightening a screw, and even a vigorous handshake should be avoided. Repeated supination using heavy rackets or weights should be discouraged. So, in below I have given pictures of wringing washed clothes, tightening a screw, and vigorous handshake, and also a repeated supination using heavy rackets, which are we need to avoid. Next, prevention of further damage. Adequate care during the acute phase, resting the elbow joint with a proper support, guiding the patient against repetitive trauma to the affected muscles by avoiding movements of supination, wrist extension, radial deviation, and tight grips. Avoiding hasty mobilization because early active movement causes repeated breakdown in the formation of scar tissue, which subsequently prolongs the inflammatory reaction and leads to the formation of adhesions. Lastly, for the restorative program to be effective, it is essential for the physiotherapist to carefully evaluate the exact nature of involvement. In strain and tear of muscle, tenderness will be present at the musculotendinous junction of the extensor carpi radialis brevis. In epicondilitis, tenderness is felt exactly over the lateral epicondyle. Granulation tissue formation as well as adhesions may be present. In bursitis, develops a bursa in the subtendinous space. And in articular involvement, painful joint movement will be present. These are the references from which I have prepared this slide. Thank you for watching. If you really liked my video, then please do like and subscribe my channel. And also, if you guys want more videos related on seminar, then please let me know in the comment below.